Good evening and welcome to tonight's program titled Answering the Call in Severe Asthma, Expanding Roles for Biologic Treatment Regimens. This activity is supported by an educational grant from AstraZeneca and provided by Integritas Communications. Now, let's give a warm welcome to tonight's presenters, Dr. Monica Kraft and Dr. Michael Wechsler. Enjoy the program.
Thank you so much. It's great to be here this evening. We've got a great program, and we're really excited to talk to you a little bit about severe asthma. The program is entitled Answering the Call in Severe Asthma, Expanding Roles for Biologic Treatment. And the kitsch here tonight, the Answering the Call, is we're going to have some phone-ins to a couple of other asthma experts who will try to answer and give their perspectives on asthma management. So thank you so much for joining us. I'm Mike Wechsler. I'm Professor of Medicine and Director of the Asthma Institute at National Jewish in Denver, Colorado. And joining me this evening is Monica Kraft. Monica, why don't you say hello to everybody?
Sure. Hello, everyone. Thanks for taking your evening to join us tonight. I'm Monica Kraft. I'm the System Chair of Medicine at the Icahn School of Medicine at Mount Sinai. So happy to be here with Mike, and let's get going.
So our goals this evening are really to talk about what is severe asthma. We're going to review some of the pathophysiology. We're going to talk about some of the new advances in asthma management. And it's been really exciting over the last few years as we've uncovered some of the novel pathways and novel targets in asthma management. And that's what we're going to talk about, including the role of epithelial cytokines like TSLP or thymic stromal lymphopoietin. And we'll talk about the clinical profiles of all the new biologic therapies with some recent trial results. And we'll also give some insight into future therapies. We're not done yet with biologics, and we still have many more to come that'll help our patients with asthma. And then lastly, we'll review some of the biologic-based treatment regimens for patients with severe asthma with the goal of trying to maximize response to the different therapies. So we're going to start off the program this evening making sure that everyone has a good understanding of what asthma is and why it's so challenging to control. It's a very complex and dynamic disease, and there are many, many mechanisms that are at play. So the first piece is to recognize how dynamic the airway epithelium is. The airway epithelium is really the first barrier of defense. And when we think about the airway, there's a normal airway, and then there is an asthmatic airway. And they're very, very different. Many patients with severe asthma are characterized with significant inflammation, a variety of different pathways. It can be type 2 inflammation or non-type 2 inflammation. The other key features of patients with severe asthma is the propensity to have hyperreactivity of the airways, twitchiness of the airways. And lastly, another cardinal feature of asthma is the fact that the airflow obstruction can be reversible and recurrent over time. People can be in a steady state and then have a significant asthma attack characterized by airflow obstruction. And this can be quite dynamic, and there are a variety of factors that can contribute to this asthma inflammatory milieu. First of all, there can be variability in terms of the airway microbiome. Second of all, there's differential goblet cell expression and differentiation. Another key feature of mucus that we're going to talk about is the prevalence of mucus in the airways, made by mucins and MUC5, amongst other important enzymes. And then there is dysfunction of the barrier, dysfunction of the interepithelial junctions, and also dysfunction of the cilial movement in the airways itself. But the tight junctions can sometimes be disrupted and allow for ingress into the airways, from the airways into the cellular milieu of microbes and other pathogens, viruses, bacteria, allergens, and other irritants. So let's take a closer look at how complex the airway is. And I'm going to first talk about type 2 airway inflammation, and then I'm going to review non-type 2 inflammation. As you can see in what I like to call an asthma confusogram, with all sorts of confusing arrows going in different directions. There are a variety of different cells that are involved. We've already talked about the epithelium, which is the first barrier of defense against irritants, pollutants, microbes, and viruses. But look how many other cells are involved in asthma pathophysiology. Dendritic cells, mast cells, T cells, B cells, innate lymphoid cells, smooth muscle cells, and then other cells like eosinophils are involved. You can also see this cytokine soup, where there is, starting at the top of the inflammatory cascade, you see the alarmins, TSLP or thymic stromal lymphopoietin, interleukin 33, interleukin 25. All of these get produced at the epithelial layer and by many of these other cells in response to different stimuli. These cytokines, these epithelial cytokines or alarmins, then activate dendritic cells and other antigen-presenting cells to stimulate T cell differentiation, activation of Th2 cells, as well as innate lymphoid cells, ILC2 cells. That's why we call this type 2 inflammation, because of the activity of both Th2 cells as well as innate lymphoid cells, ILC2 cells, producing the three key cytokines, interleukin 4, interleukin 5, and interleukin 13. Interleukin 4 is an important cytokine that's involved in activation of B cells that can produce IgE. And IgE then binds to mast cells in the presence of different allergens. When there's cross-linking of IgE with an allergen, you get mast cell degranulation and release of different mediators like prostaglandins and leukotrienes, amongst others. This is part of the atopic or allergic inflammatory process. IL-5 is a key cytokine that's involved in the activation, proliferation, and maturation of eosinophils. And eosinophils themselves can get into the tissue and cause eosinophilic inflammation. Eosinophils can then release their own mediators, eosinophilic cationic protein, major basic protein, eosinophil-derived neurotoxin, amongst others. Lastly, we have interleukin 13, which is made by both Th2 cells and ILC2 cells. IL-13 is intimately involved in acting on smooth muscle and airway hyperresponsiveness. It also is involved in mucus production, as we'll discuss, and it's also involved in nitric oxide production. And each of these can be involved in both allergic as well as non-atopic or non-allergic asthma. So it's very complex. Luckily, in the last 8 years or so, we've been able to develop several therapies that interact with these type 2 cytokines, interleukin 4, interleukin 5, and interleukin 13. And we're able to identify patients with type 2 asthma based on their biomarkers, high levels of eosinophils, high levels of IgE, elevated nitric oxide as well. Those are the markers of type 2 inflammation. And these are some of the therapies that have been developed. We're so fortunate that we now have, in addition to omalizumab that was approved in 2003, 20 years ago, just in the last 8 years, we've had development of mepolizumab, benralizumab, and reslizumab, which bind to IL-5 or its receptor. We have dupilumab, which binds the IL-4 receptor and blocks both IL-4 and IL-13. And we also now have, as of late 2021, tezepelumab, which binds TSLP and prevents epithelial alarmin activation of the downstream pathways. So we're so excited that we have options for our patients. I think of about 10 to 20 years ago, I bumped into my first attending from the early 1990s when we treated an asthma patient with 16 puffs twice a day of triamcinolone. And to think about how far we've come, that we now have more targeted approaches, and we're trying to understand what type of asthma does each patient have so we can offer them these important therapies. Another key important point about type 2 asthma is the role that mucus has in causing asthma symptoms. Mucus plugging, mucus hypersecretion. You can see in this cartoon model, this isn't what we would expect in a normal airway lumen. In an asthma lumen, the airway is filled with mucus oftentimes, and this mucus is mediated and produced by epithelial cells, mediated by interleukin-13. I mentioned MUC5AC. Monica's done a lot of work in this space. There can be loss of ciliated cells, increase in the thiocyanate transport system, as well as reactivity with eosinophil peroxidase, amongst others. So IL-13 plays an important role in mucus production, but another important cytokine is interleukin-5. And interleukin-5 as well plays an important role in mucus production. There is activation of eosinophils with release of all of the granular proteins that I already mentioned, eosinophil cationic protein, major basic protein, eosinophil peroxidase. And interleukin-5 plays a major role in the production of the mucins, the mucus that can result in the mucus plugging that we see in the airways of our patients with severe asthma. Now, we've talked about type 2 asthma, and we're all familiar with, eosinophilia, allergic asthma, nitric oxide-associated asthma. What's less well known is non-type 2 asthma, and it's much more complex. It's often thought that non-type 2 asthma is just absence of eosinophils, Ig, and nitric oxide. And what we know now by looking at a lot of patients who have low levels of those biomarkers is that there's many other cytokines that are involved. Once TSLP and the other alarmins, interleukin-33 and IL-25, are produced, it causes Th17 and Th1 production of other cytokines, including IL-17, IL-6, interferon gamma, TNF-alpha, and others. And these patients can have either neutrophilic, we talked about eosinophilic for the type 2, these patients can either be neutrophilic or they might be polygranulocytic. They may have absence of neutrophils as well. And understanding the mechanisms of their asthma can be quite challenging. The only therapy that we have that's been shown to have any efficacy in this space is blocking TSLP, which has been demonstrated to have about a 38 to 40% reduction in asthma exacerbations. It's the only biologic that's been demonstrated to be effective in that space. Now, there are other cytokines, as I mentioned, and we've started to recognize the important role that interleukin-6 plays. And we're learning more and more that perhaps it might be more of a systemic inflammatory process, as identified by IL-6 levels. Sometimes C-reactive protein is identified as a surrogate marker of interleukin-6, but we really don't have any great biomarkers. But there are a lot of things to target. And Monica and I and others are working as part of the PRECISE network, an NIH-sponsored network called the Precision Interventions in Severe or Exacerbating Asthma Network. It's operating in 30 different centers around the country, and we're targeting things like interleukin-6, with specific monoclonal antibodies, as well as other strategies. So I'm excited that we're right now have one therapy that works in this space, and we're hopeful to have other therapies down the road. We've talked about the epithelium. We've talked about everything below the epithelium, all the cells that are involved, from the mast cells and eosinophils. When we get down to the lower levels of the airway, it's important to consider the important role that airway smooth muscle plays. It's really the final common pathway in asthma that results in airway hyperresponsiveness, bronchoconstriction. It also plays a role in narrowing and also airway remodeling, the concept that there can be fixed airflow obstruction in patients with thickened basement membranes all the way down to hypertrophy of the airway smooth muscle, such that patients may have low lung function that doesn't respond to any therapies that we have. The other important cell that's involved in airway smooth muscle is the mast cell. And the airway smooth muscle releases a variety of different mast cell mediators that can play a role also in mucus hypersecretion and also in the other inflammatory processes resulting in airway smooth muscle mass increases. We're still trying to understand. We're really in our infancy, I feel, in terms of appreciating the role that airway smooth muscle plays and also the role of what's going on in patients with non-type 2 asthma. But like I said before, we're fortunate. We have 6 biologic therapies. Omalizumab that targets IgE, reslizumab that targets IL-5, and mepolizumab that targets IL-5, benralizumab that targets the IL-5 receptor alpha, dupilumab that targets the IL-4 receptor alpha and also blocks IL-13 activity, and tezepelumab, which targets thymic stromal lymphopoietin, or TSLP, that upstream alarmin that we talked about that's at the top of the inflammatory cascade. The other thing that we're excited about is that not only are some of these therapies approved for just asthma, but also a lot of the related type 2 comorbidities. Omalizumab is also approved for urticaria, for instance, as well as chronic sinusitis. Mepolizumab is approved for chronic rhinosinusitis, nasal polyps, as well as hypereosinophilic syndrome and eosinophilic granulomatosis with polyangiitis or Churg-Strauss syndrome. Dupilumab is approved for a multitude of indications, including atopic dermatitis, eosinophilic esophagitis, and chronic rhinosinusitis with nasal polyps. And tezepelumab, just approved in the last year and a half, also works well in patients with non-type 2 asthma. So we have a plethora of therapies. We're so fortunate, our patients are so fortunate, because these therapies have really revolutionized the way we approach our patients with asthma. So now I'm going to pose a question to our colleague, Jonathan Corren, about targeting upstream versus downstream mediators of disease. Does it matter? Jonathan.
That's a really important question, because right now, all practitioners who treat moderate to severe uncontrolled asthma are faced with a very good list of possible therapies that they can use in these patients. So we've been really faced with the challenge of, should we go more upstream with a broader approach, or are we better off really focusing on very specific targets like IgE or specific individual cytokines? And I think when you think about a very difficult patient, there are some reasons why we'd want to go upstream. First of all, when you have a broader approach, you're going to be affecting potentially multiple cytokines instead of one. For an example, if you can block something like IL-33 or thymic stromal lymphopoietin, TSLP, then the chances are you're going to affect cell activations. And those cells are responsible for the generation of cytokines IL-4, 5, and 13 in many cases. So you're able to hit things that really control a variety of different mechanisms that contribute to asthma. In the case of IL-5, certainly eosinophils. In the case of IL-4 and 13, exhale nitric oxide being the biomarker, which really has to do with the effects of those cytokines being airway hyperresponsiveness, mucus secretion, and many other activities. Another important reason to go upstream, potentially, is that you're going to affect non-type 2 mechanisms. For example, we understand that TSLP can have direct effects on smooth muscle activation, in which the smooth muscle becomes capable of synthesizing its own cytokines, including TSLP. So you end up with a positive feedback loop in which TSLP activates the muscle makes TSLP, and so on and so forth. This may be relevant to many different phenotypes, not only type 2, but non-type 2 as well. And another potential mechanism that is really not type 2 focused is non-IgE dependent activation of mast cells, which again may be relevant to allergic asthma, non-allergic eosinophilic asthma, and low type 2 asthma. I think the final thing to consider is we think of patients in phenotypes, but very often they can flip from one phenotype to another. There have been multiple papers now demonstrating, particularly if people are in the range of 150 to 300 eosinophils, or in the much lower ranges of exhale nitric oxide, that they may become, for periods of time, what we would call a low type 2, and then during certain triggers may become high type 2. So we'd really like to cover some of the basic mechanisms that would be applicable to all of these phenotypes. One question is, when should we really think about being more focused? And I think the level of biomarkers really helps us make this decision. In people with very high eosinophil counts, and I'm talking 7, 8, 900 cells per microliter of blood, an approach that really targets the eosinophil more directly, such as an anti-IL-5 or an anti-IL-5 receptor, might be more apropos. And consideration of comorbidities, things like nasal polyp disease, atopic dermatitis, eosinophilic esophagitis, if present and are significant problems, may dictate our choices of medications. So I think there's a lot to consider here, and I'm condensing a lot of information into a very short span, but I hope this helps.
My friend.
Yes, exactly. Thank you, Jonathan. All right, well, now that Mike has very eloquently described all of these amazing targets that have been discovered in asthma and the airway, I'd like to move on and talk to you about some newer therapeutics. What are some things on the horizon? And of course, if we look at this slide, we can see a lot of activity. And so first, we heard about the alarmins very nicely from Mike, and you can see that there actually are a couple of studies in the works or actually have been completed that are actually looking at inhibiting these. Of course, we know about tezepelumab, we saw that, but then there's also an inhaled anti-TSLP that has actually finished, it's actually completed and is not moving forward. Then there's an anti-IL-33 that I'll tell you about that actually looks very interesting in asthma, but actually is being developed in COPD. And then we have a second IL-33 inhibitor as well. And then we have astegolimab, which is an ST2 inhibitor. ST2 is the receptor for IL-33 that is expressed on many cell types, including the innate lymphoid cells. And in fact, so going that route is also very interesting in terms of inhibiting the effects of that cytokine, and that's moving along as well, really more of a focus in COPD. There's also an interest in mast cells and their products. Of course, we know they express IgE, and then they degranulate. And so we've got two in the works, two tyrosine kinase inhibitors, masitinib and imatinib, and I'll show you some interesting work being done there. And then, of course, we heard about IL-6. So IL-6 is very interesting because there's a classic and a trans-signaling approach that IL-6 does, and so it can be very prominent in an obesity phenotype with metabolic syndrome. And so there are some very interesting IL-6 inhibitors in the works. We're actually looking at one in the PRECISE trial, as Mike mentioned. And so we'll go ahead and go through a couple of the data slides so we can show you where these emerging therapies are. So this is really just to review the Navigator trial, which is the anti-TSLP. And we can see that with that, we saw a very nice reduction in exacerbations in the overall population, as well as those who had more than 300 eosinophils per microliter, more than 150, and even less than 150. So this is the non-sort of T2 group that we were talking about. We still saw a nice 39% reduction in exacerbations. And as Mike mentioned, we really don't have as much to offer this non-T2 group, and so this is exciting data for sure. And other tezepelumab studies that are going on, just for your information, the Destination study, which is a long-term extension study, looking at severe uncontrolled asthma. These are the participants that completed the Navigator study that you just saw, or another study called the SOURCE trial. There's Passage that's actually looking at real-world effectiveness, and I actually appreciate this one because it's in a broad population of adults and adolescents with severe asthma, including those underrepresented in clinical trials. And I think it's really important to think about all of our population with asthma, and sometimes our trials have not been diverse enough, and I think the role of Passage is to really address that. And then Wayfinder is a study to evaluate efficacy and safety in reducing oral corticosteroid use. So as you know, there was one oral corticosteroid study that did not meet its endpoint, but there's another one going on because there was some questions about whether maybe a slightly different design or an increased sample size may be necessary, because several of the other biologics are steroid sparing, and it's a little perplexing why tezepelumab wouldn't be. So I'm actually really glad that this Wayfinder study is going on. Okay, so itepekimab is an anti-IL-33 study, and this is the phase 2. These are the data. And I don't know if you remember the old dupilumab studies, the phase 2. They had an interesting design where patients would come in, participants would enter the study, then they would undergo a withdrawal of their long-acting beta agonist, and then a withdrawal of their inhaled steroid to really see what these interventions can do. And so these 4 lines represent placebo is blue, then you've got itepekimab and dupilumab combination in yellow, itepekimab alone in green, and dupilumab in red. And we're looking at cumulative incidence of loss of asthma control and change in eosinophil count. And so looking really at this graph for sure, you can see that itepekimab and dupilumab were pretty closely aligned. And I think that's my hypothesis, and that's what I'm told when I talk to some of my industry colleagues as to why the work is now being changed, or the goals of itepekimab is moving into COPD. Although I still think there's some very nice results in asthma too, but that's my opinion. So looking at another anti-IL-33, this is a phase 2A proof of concept. You can appreciate here looking at the change in FEV1 from baseline, as well as change in eosinophils. This is looking at itepekimab and placebo. There's some differences that you see, but I think there was an internal decision made not to continue with this particular biologic. I think the space is getting really competitive, and I think the results have to be pretty compelling to move forward, because I think we have several biologics at our disposal already, as you've seen.
I think if some of these therapies had been developed 10 years ago, this would be the go-to drug, a no-brainer, because the results are so good.
Absolutely. And then astegolimab, which is this anti-ESP2, remember the receptor for IL-33, also looks quite nice in terms of overall reduction in annualized exacerbation rate in those who had EOs less than 150, maybe not quite as compelling as those with greater, but still had some effects. But again, this has also been discontinued in asthma, but looking at it in COPD. All right, looking at the mast cell mediators, as we talked about, this is masitinib, a tyrosine kinase inhibitor. Looking at oral corticosteroid-dependent asthma, which of course is less of a problem than it used to be, but there are still patients, I certainly take care of them, who do require oral steroids. So it was really nice to see that this had some benefit in that group with a nice reduction in exacerbations. And so actually the phase 3 has been completed. So at this point, hoping that we're going to see approval, but I'm not sure exactly where that is in the pipeline. Now, imatinib, this was done in a phase 2 proof of principle study in a few centers around the country. Actually, a subset of the centers doing PRECISE. And I think what's interesting about this is you can see there was actually a reduction in airways hyperresponsiveness, which is something you don't see that often in trials. One, because it's not so easy to do that in the setting of a large trial, but also it can be a very difficult endpoint to reach. So I was very happy to see that imatinib had that effect, and that tryptase, which is a mast cell marker, decreased. So because of these results, we decided to look at it in a much larger multi-center way as part of PRECISE. So more to come on this one. All right, now I'm going to hand this back to Mike so we can move on to the next section.
Yeah, so there are a lot of challenges surrounding the use of biologic therapy, and a lot of clinicians have questions about the timing of initiation, what predicts response, and how to select which biologic therapy is best for which patient. And an important concept, and Monica highlighted already the fact that there's many patients who are on oral corticosteroids still. Not as many in the United States, but globally, there's a lot of patients. And when you talk to patients who have severe asthma, 75% of them report that they had at least one use of oral corticosteroids in the prior year. And still, today, there are about 8% of patients who report that they're on daily maintenance oral corticosteroid therapy. The last iteration of the GINA guidelines, the Global Initiative for Asthma Guidelines, said that in 2023, it's high time that patients not be on oral corticosteroid maintenance therapy. And yet, there's so many patients, at least 30% of severe asthma patients with high oral corticosteroid exposure are not receiving any of the biologic therapies that we have available to us. And so it's important to understand, the complexities of steroid use. They are associated with significant toxicity, from cataracts and glaucoma to osteoporosis to depression to anxiety to all sorts of side effects, hypertension, weight gain, diabetes, cardiovascular disease. You go through every system, you'll recognize that oral corticosteroids are associated with significant morbidity, and that morbidity is associated in a dose-dependent manner. The more corticosteroids the patient is on, whether they're on them chronically or even intermittently, we've shown that there's a higher risk of toxicity. And the evidence suggests that type 2 biomarker low asthma symptoms don't even benefit from oral corticosteroids. So why are those patients continuing to get oral corticosteroids? We need to think about what can be done differently to help reduce oral corticosteroid exposure in our patients. As little as one course a year can be associated with significant toxicity. There was a study called the Chronicle study, and this is an ongoing real-world observational study. It included 959 patients with confirmed severe asthma diagnosis. And of those, only 41% subsequently initiated biologic therapy. And the median number of days between the last exacerbation and their biologic initiation was over 2 months for these patients who had exacerbations versus 36 and a half days or so, which is still a fair amount of time for patients with at least one exacerbation. Since that time, there's been an interim report that Brad Chips has highlighted of 908 of these patients. And we know that the biologics work. Looking at these data, 68% of these patients had no oral corticosteroid use within the prior year once they started a biologic. These are for patients who start a biologic. They went from 60% had an exacerbation to 68% did not have an exacerbation, essentially cutting the exacerbation rate in half. And the majority of these patients did well. 35% of them actually achieved good asthma control, as identified by an asthma control test score of 20 or more. So one of our major goals in asthma management is recognizing the severe asthma patient, recognizing the toxicity of oral corticosteroids, and then expediting, trying to get these biologics into the patients early enough so they can prevent some of the long-term damage, so they can prevent some of the corticosteroid toxicity in our patients. When we think about inhaled corticosteroids or oral corticosteroids, we have to recognize that there is a dose-response limitation. There's a flattening of the dose-response curve. When you go from low to medium to high dose inhaled corticosteroids, which we do in all of our patients, right? We start off low dose, we bump up to medium dose, we then go to high dose. But look what happens. Yes, you get an improvement in FEV1. Yes, you get an improvement in peak flow. Yes, you get an improvement in rescue medication use. But once you get to high dose, that response flattens out. The problem is, however, when you look at side effects, the more corticosteroids the patient is on, these are inhaled corticosteroids, inhaled. Increased risk of adrenal insufficiency, increased risk of cataracts, increased risk of diabetes and osteoporosis or non-vertebral fractures. So we have to recognize that even inhaled corticosteroids have some toxicity. And when we give doses of inhaled corticosteroid, we shouldn't avoid using them, but we need to recognize the toxicity and think about all the potential side effects. So let's ask one of our other colleagues, Dr. Nijra Lugogo from University of Michigan. The high bar for biologic initiation, Nijra, when is it too early?
I'd love to give my perspective on this topic. It's one of my passion topics, actually. And, I feel like our thresholds are far too high. And to me, there's a lot of data now indicating that in order to achieve remission for our severe asthma patients, we really need to target the disease earlier in the course. The predictors of remission include early onset disease, having asthma less than 10 years duration, and preserved lung function, which indicates to me that we need to intervene before we have irreparable damage to our patients. Now, a lot of times when you talk about irreparable damage when it comes to asthma, we are really thinking about lung function. But for many of us who manage severe asthma patients, we can tell you that although asthma is a lung disease, the consequences of exposing patients to oral corticosteroids, having them miss days from work or school, or worse yet, becoming disabled because of their disease, or really limiting their activity and enjoyment of life can go far beyond the lungs. And our patients suffer tremendously, giving up so many things in order to accommodate their limited ability to function because of their asthma. So as pulmonologists and allergists and clinicians here in the room, we are thinking about lung function and preventing remodeling, but maybe we should really think about the patient as an individual and all the unintended negative consequences that are occurring when we wait far too long. We have wonderful choices. You covered this quite well. We have 6 biologics currently to pick from, and a lot of our patients are eligible for biologics. Now, I don't think everybody should get a biologic, but we really need to move away from a reactive way of managing patients to a more proactive way of identifying high-risk patients, getting them on therapy early, mitigating the negative consequences of exposure to oral corticosteroids, and frankly, life-threatening exacerbations, which unfortunately in the US still currently results in the death of almost 4,000 people a year. So what I believe we need to do is change our paradigm of thinking and start to identify people who don't have difficult to treat asthma, in that you've optimized their inhaled therapies, you've provided them with education on how to use their medication, you're confident that they're adherent, and then quickly moving on to identifying phenotypes and people that have type 2 inflammation, significant exacerbations, oral corticosteroid dependence, low lung function, and moving those patients rapidly onto biologics to stabilize their disease, much like they do in rheumatoid arthritis. And once the patients are stable, you can always come back in the future, and we don't have a lot of data yet on how to get people off biologics, but I think the initial focus should be risk mitigation and stabilization. So when is it too early? I suppose it's too early if you really haven't optimized the patient, identified poor adherence and issues with medication utilization. It might be too early if the patient isn't on any inhaled therapy, although I don't think we need to continue to wait a significant amount of time after initiating therapy, because certainly every one of us have seen patients who went from having relatively benign disease to very aggressive, severe disease in a pretty quick fashion. And those patients should really be escalated a little bit faster. And so I believe we need to tailor this to each patient, but we need to be thinking, what kind of damage is our patient suffering? How can we mitigate that early? Have we optimized all the other therapies apart from biologics, and doing that in a pretty rapid fashion? And here I'm talking about months. And then making a decision, moving on to biologics, and allowing our patients to restore their lives to normalcy. I mean, that's what I would want for myself, and I think we all want to intervene a little bit earlier in the course to allow patients to have preserved lung function, to be able to keep their jobs, to not have oral corticosteroid toxicity, and to be able to continue to enjoy their lives, as many of these patients are actually in their prime when they develop severe asthma, with a mean age of about 53 years old. And so I believe when biologics become a little bit more affordable, we'll become a little bit less likely to hold off, but we probably need to get moving a lot faster than that, mimicking the rheumatoid arthritis patients and patients with inflammatory bowel disease, and really thinking about risk mitigation quite early in the course of disease once you identify patients that you know are not going in the right direction. So I hope this has been helpful for you. When you get to the disparities part of the program, please give me a ring. I have some thoughts I'd like to share on that.
So this is another online survey. This is the pre-meeting clinician poll. So you can see that the answers were a little bit more spread out, but I think this insurance denial access is still a major issue. And then, of course, selection seems to come next, and patient reluctance is in third place, and then the others are pretty close together. So interesting. So we're going to take those on. All right, so I'm going to start with the questions. So Mike, how do you select initial biologic therapy?
Yeah, it's so important to think about and not just willy-nilly give a biologic to your patient. Obviously, as Nijra mentioned, you want to make sure adherence is addressed, comorbidities. But then what I ask, the first question is what type of asthma does this patient have? And I look at the biomarkers. I try to identify a dominant biomarker, whether it's eosinophils, which may reflect IL-5 activity, nitric oxide, which may reflect IL-13 activity, or IgE, which reflects more of an allergic disease pattern. Then I also want to look at comorbidities. Can the biologics that I'm thinking of address maybe some of the patient's other comorbidities, whether it's chronic rhinosinusitis, whether it's atopic dermatitis, eosinophilic esophagitis, urticaria? Can those be addressed with any of the biologic therapies? And then I talk to my patient about, in a shared decision-making process, about what are the goals of the patient in terms of how frequently the medication is given, where the medication is given in the office or at home. Are there insurance issues and co-payment issues? So those are some of the things that I think about. And many patients don't have a single dominant biomarker, so then it's how to parse out deciding between one biologic versus another. And I'll make a decision, and if it doesn't work, I can always make another choice. What about you, Monica? What are your...
I would say very similar. I tend to, I want to make sure I'm dealing with severe asthma, so maximally treated with high-dose ICS-LABA generally. Despite the dose response, we'll still try that. In addition, addressing the comorbid conditions, and that asthma gets worse if I try to taper the medication. So they're really optimized from a medication perspective, but still poorly controlled. And then, of course, I'll look for another T2 comorbid disease, as Mike mentioned, because that actually might make the decision easy. If they have atopic dermatitis, I would go with dupilumab. If they have chronic rhinosinusitis with polyps, dupilumab is first line. However, in childhood onset, omalizumab can be helpful, and in adult onset, mepolizumab is useful. And so that would sort of help you make your decision. So if they don't have another T2 comorbid disease, then I'll go to eosinophil counts first, but I like to measure FeNO, but I also realize that not everyone has that, and I'll sort of march up the eosinophil level. If it's less than 150, then I'll think, well, is there anything to go for allergy? Any skin test positivity or blood testing, or is the FeNO elevated? If I don't see any of that, I'll go with tezepelumab. If I do, I could still use tezepelumab, but I might consider omalizumab or dupi. If we're marching up the eosinophil numbers, 150 to 300, I think the most experience is probably around dupilumab, but you could also make an argument for tezepelumab as well, or omalizumab. And then if you get to the higher levels, say 300 to 1500, then again, you want to see, does your patient have anything going for an IL-13 driven process? Is FeNO up? Or is there any sensitivity to aeroallergens? Because if you're seeing that, then you may decide to go with dupilumab or omalizumab, but if you don't see that, then definitely think about an IL-5 or IL-5 receptor inhibitor. And then, of course, some of our patients have really high levels of eosinophils, 1,500 and above, and then I start to worry about other diagnoses, hypereosinophilic syndromes, EGPA, and do that workup first. And if I don't see that, then I'll go with an IL-5 receptor inhibitor or IL-5 inhibitor. And just as a little plug, because what we just said is rather complicated, if you're an up-to-date person, I'm one of the section editors, and we've worked out an algorithm with Sally Wenzel and Paul Diefenbach that sort of lays it out, and also in patients who are oral corticosteroid dependent as well, that might help navigate this a little bit. So just want to let you know it's there. That might be helpful to you.
And Eileen Wangan and I from National Jewish wrote an article this past year about the same thing, using a bit of an algorithm approach. And Monica and I also co-authored an article with Roland Buell and other colleagues about how to approach biologic therapy using a nice algorithmic approach that, they're quite similar, utilizing biomarkers and going through the comorbidities and other factors that we utilize.
Absolutely.
So I think we're going to talk about what if a patient qualifies for one or more biologic therapy.
Right. What do you do? Yeah. And you can tell from what I had just said and what Mike just said there, it's very common that they qualify for more than one. So how do you sort of navigate that? And using an algorithmic approach can be helpful. And then once you decide on one to choose, you give it a try for 4 to 6 months. But what you ultimately decide might have to do with how often the dosing is given. Every 2 weeks versus every 4 weeks versus every 8 could also factor into the decision. What does the patient feel comfortable with? But then ultimately, if you decide to try one, usually you want to give patients a bit of a time period. 4 to 6 months is probably the least amount of time, especially exacerbations are what you're really looking at as a readout. But with some of these biologics like dupilumab and even the IL-5 inhibitors, there's some change in lung function that you can see and some improvement in symptoms, so it's important to track all of that. But I think what gets tricky in clinical practice is you really want to be sort of systematic about how you track improvement so that you know where they were at baseline, you can really reassess 6 months later, and if they're really not responding at all, then it would be time to make a change. What do you do, Mike?
No, exact same approach. Again, going through, we can always try one, we can always switch, but I do want to give it some time to work unless there's some adverse effect, which is quite unusual. In certain circumstances, I've even used multiple biologic therapies if they have other comorbidities. You know, for instance, if I've lowered their eosinophil counts with anti-interleukin 5 therapy, I might consider adding on, if their insurance will cover it, another biologic therapy that maybe targets IL-13, like dupilumab. Now that we have tezepelumab, which works at the top of the inflammatory cascade and seems to lower eosinophils as well as Ig and nitric oxide, I'm doing that a little bit less.
Right.
But these are, you know, it's good problems to have that we've got multiple therapies that we can choose from.
Right, and if you're treating one of the T2 comorbid diseases, let's say you're giving dupilumab for nasal polyps, and the asthma is getting better but maybe not completely controlled, so partial response, you could actually make a case for adding another biologic in that setting for the asthma. Or the atopic dermatitis gets dupilumab, and then you can treat the asthma with a different biologic. And that's actually quite doable today. You can do that. All right, so Mike, you know, we of course saw in the poll, insurance challenges are huge, and it takes a village sometimes to get these biologics approved. So how do you overcome insurance challenges that impede access to biologic therapies, especially to some of our most vulnerable patients?
Yeah, you know, it's tough. And remember, these therapies, they're not inexpensive. They can be quite costly. And so payers reflexively will want to deny some of these therapies. All the biologics have gone through this. And so my general approach is to lay out a case up front. And whenever I submit the paperwork for these biologics, I make clear documentation of why I'm doing it. It's also helpful for me to follow these outcomes so I can know whether or not the patient is responding. And I'll document, well, this person had X number of exacerbations, usually at least 2, and or they're poorly controlled, they're symptomatic, despite use of high doses of inhaled steroids, long-acting beta agonists, plus or minus some other therapy. And if you make a good case up front, then you don't need to go through the insurance challenges. Most of the time, whenever I get a denial, it's because the paperwork didn't make it through, my last note didn't make it through, or something. But sometimes it happens. And what I do then is I look at the number on the denial, and I give them a call, and I say, I'd really like to make an appeal of this. Because look at this patient. Why should they suffer? And in fact, most payers are quite sympathetic to that. Why? Because every emergency room visit costs them a lot of money. Every hospitalization costs them a lot of money. And it can be very, very costly. So they want to prevent the exacerbations. On top of that, they also recognize the long-term consequences of oral corticosteroids. They may not be paying for the osteoporosis or cataracts or glaucoma now, but they will down the road. And so they're recognizing that a little prevention now may be helpful down the road.
Absolutely. You know, I had an interesting situation, and I'm sure many of you have too. So I had a patient with non-T2 asthma, had a severe exacerbation, had several the year before, and so wanted to prescribe tezepelumab. And got a nice little note from the insurance saying, well, she'll need to fail 2 other biologics before she can have this one. And she didn't qualify for the other 2. So we really had to, and they did not have a peer-to-peer option, because of course I would have liked that. So we did an appeal. Actually, we had to do 2 sets of appeals, which I had to write a letter, and then I really had to flesh out in the assessment and plan of my note. I think that was probably the most effective as to why she's a candidate for tezepelumab and not the others. And then we finally got it approved. But I think one of the challenges is if you don't necessarily have a team to help you, this can be difficult. And they have, and if you have a smaller practice, they have to do other things besides work on prior auths all day. So I can understand how this could be a challenge. One other piece that's come up is the copay sometimes can be quite high, and some of the biologics actually have patient assistance programs. They don't all, but some of them do. I think dupilumab does, and I think tezepelumab does, and I'm not sure about some of the others. I don't think the others do. And that has been a barrier in my practice as well, despite getting the biologic approved. It's the copay that was really the challenge. So just a few other thoughts like that. All right.
So how do you address patient reluctance? Sometimes there are some patients you say, listen, let's start a biologic therapy, and they're like, well, what's a biologic therapy? Or you say, let's start a monoclonal antibody, and they get a little bit freaked out. Or they may have needle phobia. My wife has terrible needle phobia. Like, I had to sedate her to get her COVID vaccines. And so how do you address sometimes the patient reluctance for any of those reasons to initiate a biologic therapy? What do you tell them?
Right. Well, it really is a shared decision-making moment, because especially by the time you get to this conversation, they've seen you, if they're new to you, seen you a few times. You've done this evaluation of their comorbid conditions and their biomarkers, and really you have to take the time to sit down and explain a little bit about asthma heterogeneity, what kind of asthma they have, and then how a biologic could benefit them. One other piece is between the high-dose ICS-LABA and the biologic, you could try a course of macrolides. That's something else you could try as a kind of a pre-biologic, if you will. That's actually in the GINA guidelines. If patients prefer to really try everything before they move to that. And then really, we talk a lot about dosing in terms of how comfortable they are giving themselves injections. Can they do it? Can a family member do it? What are their fears? Sometimes patients will just come into the clinic to get it. They would rather not do it at home themselves, and we, of course, offer that option. But I would say for the majority have embraced giving themselves injections. I was actually a little worried when the home injections became approved. I was very worried about it. But I'd say, at least in my practice, most have caught on because we bring them in for good teaching. And so that hasn't been as big an issue as I thought, but there still are. And then, of course, I get the question, how long do I have to be on this? And I think that's probably where we have the least data in terms of understanding how we can lengthen the time between doses or decrease the dose. Oftentimes when you start adjusting that, it's hard to be able to continue that biologic because the insurance carriers that are covering this want you to provide the recommended approved doses. So I feel like this is a little bit of a gray zone, wouldn't you say?
Yeah, no, absolutely. So it's a challenge, and I'll tell you, I rarely stop willy-nilly a biologic therapy because the challenge of restarting and getting insurance authorization can be that much harder a second time. And so what I do, and first of all, there are some data that are emerging, and we're doing studies now about what happens when you stop a biologic. And yes, some patients do fine. There's a subset of patients that do okay. But many patients, within a couple of months of stopping the biologic therapy, they end up having relapses. That can be sometimes identified by some of their biomarkers, but then their symptoms, their rescue medication use, they are at risk of another exacerbation. So what I do in an off-label manner is after a year of stability, and they really have to be stable for a full year, and what my goal is to try to get them and evaluate them for whether or not they've achieved remission of their disease. So remission is a relatively new concept, and Monica and I have been talking about it. I've got Dr. Rhodes in this second table there who just published an article about this topic. What is asthma remission? It's a new concept. It's the concept that you have, yes, there's asthma control and patients don't have symptoms. They have an ACQ score less than 1.5 or an ACT score greater than 20. But they also don't have exacerbations. They have no steroid use. They have stabilization of lung function. And you have to have that over the course of a year. So if I see those features, and we're not even talking about biomarker normalization, although that's helpful as well as a predictor, then if I see that they've achieved some degree of remission, then I will think about increasing the interval between doses to see whether or not they can come off. Maybe go from every 4 weeks, every 5 weeks, every 5 weeks, every 6 weeks. And then if they could go for 3 months or so without some of these therapies, I feel much more comfortable. Do you know what proportion of patients actually can achieve that remission? Meaning no steroids, no symptoms, normalization of lung function for the course of a year with these biologic therapies? Anyone? Yeah, it ranges. That's a great guess. It's somewhere between the lower range of about 12% up to about 38%, depending on the clinical trial and depending on the specific therapy. And now there are some ongoing studies trying to evaluate using remission as a primary outcome for some of these biologic therapies.
Right, that's exciting. And there's also a study going on, and there are several that are being considered of using these biologics earlier in life. In our pediatric population, especially children at risk for asthma, given their family history, presence of another atopic disease, for instance, and seeing if these biologics can be disease modifying. So we have remission on the established side, disease modifying in the pediatric population, so maybe they'll never develop asthma. So I think that's a really exciting concept as well. All right, let's talk a little bit about disparities in biologic utilization, because I think as we talk about insurance coverage, oftentimes it's some of our most vulnerable patients that we have the most difficulty getting these biologics. So what are some considerations? And so we look at this, about 1 million patients have severe asthma in the United States. 40% have been seen by a specialist. 65% are prescribed a biologic. 35% are not on a biologic, despite uncontrolled severe asthma or OCS use. I think that statistic is not acceptable. And 60% are assumed to be managed by primary care. And I've always had this feeling that there are these, and I know this, that there are these patients out there in primary care practice who are on high-dose ICS-LABA. They exacerbate once or maybe even twice a year, and somehow that's okay. That's the normal state of affairs. And so I've been trying to really work with my primary care colleagues across our health system to say, that's not where you want to be. That is a failure of therapy. Please send them our way, because we have options for them. So it's just a matter of education. So I think we have disparities in biological use in the U.S. Patients with the highest rate of receiving biologic therapy are white adult females with an annual income of greater than $75,000 a year, managed by a specialist. Those with the highest rate of asthma mortality and ED visits due to asthma are Black adult females, but also Black, Hispanic, and Indigenous individuals in the U.S. have the highest burden of asthma compared with white Americans. And one of the challenges is that in the trials we do, we really have to be mindful of making sure we recruit participants that really reflect our population, because asthma is not a one-size-fits-all, we know that, and there can be huge heterogeneity across race and ethnicity. And so although these biologic therapies represent a new dawn, they're not accessible to all patients. So some of the factors that contribute to disparities in biologic use could be certainly race and ethnicity. There's biological factors, which may be genetics, nutrition, smoking, microbiome, and diet. There could be behavioral, sociocultural, environmental factors around education, health insurance, health literacy, therapy adherence, and psychosocial factors, and socioeconomic status. An environmental and health system, there could be housing issues, quality of indoor air, outdoor pollution, access to health care, and trust in the healthcare system. And so severe and poorly controlled asthma disproportionately affects the Black population, and asthma mortality is 4 times as high among Puerto Ricans and Black Americans as among white. Those are astounding statistics. Yet they represent only 5% and less than 1% of clinical trial participants respectively. So clearly there's work to be done. So speaking of that, let's call a friend, call a colleague. So addressing disparities to care head on, how can we do better? So Dr. Lugogo, what do you think?
Hi again, Monica. This is an area of great concern within asthma management. I mentioned earlier how passionate I was about starting biologics early, and I'm going to say that this is also an area of significant passion for me. I guess I have enough passion to accommodate multiple interests, and health disparities really speaks to me because, unfortunately, in 2023, we still have issues with access to care that result in poor outcomes that don't affect all groups equally. We know, for instance, that African American patients, particularly women, suffer the burden of asthma and are more likely to have severe disease and even to die of asthma. African American children are more likely to have emergency room visits and hospitalizations related to asthma. These are things that we have seen in our own statewide quality improvement initiative, where we are focusing on trying to improve asthma outcomes across the state of Michigan. Now, it turns out that it's not because these patients aren't going to respond to therapy. In fact, A lot of times our African American children and adults have more type 2 inflammation, meaning that they would benefit from biologic therapy. In addition, when you look at data from our registries, such as Chronicle, and we will present an abstract at this meeting on this topic, patients that were underrepresented in clinical trials responded equally well to biologics. So African American patients responded equally well to biologics. In addition, we often have our patients receiving care in environments where chronic disease management is not the focus of care. And so when you look at at-risk populations and poor access to care, a lot of those patients seek care in emergency departments and urgent cares, which are really areas for stabilization and not areas for chronic disease management. So naturally, if you're seeking care in an emergency room, you're going to get oral corticosteroids and a short-acting beta agonist because the intention all along is for you to go on and get care from your primary care physician or your specialist. Unfortunately, what we've seen in our own data is that about 40% of these patients get care nowhere else but the emergency department, which means that they will repeatedly use short-acting beta agonists and oral corticosteroids. Now, we all know that there's enough data now to suggest that it is not okay to use more than 3 short-acting beta agonist canisters a year, particularly when this is being used as monotherapy. You have increased risks of exacerbations, hospitalizations, and even deaths related to relying heavily on short-acting beta agonists in the absence of inhaled corticosteroids. The other thing that always strikes me is that patients really have very low expectations. Our asthma patients have sort of come to believe that asthma is a disease that you may or may not be able to control. They have no expectations that they'll be able to actually reduce their asthma burden so significantly that they can live normally. So they simply make their lives smaller and smaller. They do less. They don't go out with their grandchildren or children or family members. They don't travel. They don't dare go outside when it's hot in the summer, when it's too cold in the winter. They sort of give up so much because they don't really expect a different outcome. Now, not receiving good asthma care versus not receiving effective medications just really comes down to patient advocacy. And what I've personally started to say to my patients in the clinic is, you should hold me to a high enough standard where you're expecting me to get your asthma to the point where you can do whatever you want to do. And I should work hard partnering with you to get you where you need to be versus simply capitulating and accepting that we need to shrink your life down because you have asthma. And so I think our patients really need to have a certain level of activation, self-advocacy, demanding better, asking questions of us, understanding what poor asthma control is, and wanting to achieve not only control, but recently we've started to even talk about remission. And I think that is an aspirational goal for both us and all of our patients. Now, I could share multiple stories of people coming to be oral corticosteroid dependent, requiring biologics, and being able to be liberated of their oral corticosteroids. People going back to work, people sharing stories of enjoying their lives again, their grandchildren and their families. So we really need to hold ourselves to a high standard. We need to always work with every patient, think about why these disparities are occurring and target them as much as we possibly can in order to improve outcomes for all of our patients. They deserve that. I hope I've shed some light on this critical issue. Thanks for the call. Let's get together again soon. Thank you so much for having me.
Thanks, Nijra.
Great points, absolutely. All right, so we've come to the end of our program, and just to conclude that 6 biologic therapies are available for the treatment of severe asthma, so it's an amazing time to be in this space. But despite revolutionizing the treatment, there's still unmet needs and healthcare disparities, and they persist with regards to utilization of these biologic agents. Current challenges include initiation, the initial selection, the monitoring, the switching, and the access. As precision medicine continues to evolve, we look ahead to explore newer treatment targets. We heard about some emerging therapies tonight, define biomarker thresholds and refine treatment eligibility, and I would say increase the number of biomarkers at our disposal, and investigate outcomes in a broader underserved patient population.
Thanks.
So, interesting question. How big a role, if any, do you believe digital tools have in helping patients being prescribed biologics better manage their disease, as well as being an avenue to collect real-world data? Love that. I actually think that's where things are moving. There's an interesting study being done at Mount Sinai and others called Regain, where that's actually being done. There's a lot of data collected on a cohort of severe asthma patients, and using digital tools really around the iWatch to monitor when they are at risk for exacerbations. This is sort of another role, another pathway, meaning if all of a sudden their heart rate goes up, their SAC goes down a little bit, you can kind of predict maybe when an exacerbation may happen. Especially for those poor perceivers, this can be very valuable. You want to do the next one?
Oh yeah, I got one. So in a patient on dupilumab with outstanding clinical response, but the blood eosinophils go from 300 to 1200 without any side effects, what would you do? So this is a well-appreciated, expected outcome of some patients on dupilumab. Dupilumab blocks the IL-4 receptor and also blocks IL-13 activity. And by doing that, IL-4 and IL-13, and we didn't mention this before, are important cytokines that are involved in the trafficking of eosinophils from the blood into the tissue. So what happens if you block IL-4 and 13? The eosinophils don't go from the blood into tissue, they stay in the blood. So it's an expected phenomenon, and we do see elevations. In fact, I published this past year on all of the dupilumab clinical trials and demonstrated that there's a transient increase in eosinophils. It can be as high as 1,200, but most time it's in the 500 to 800 range. And then there is mean reduction in eosinophil counts. The vast majority of patients don't have any clinical side effects. That being said, what I do is I monitor these patients. I look for it in some of these patients, particularly if they had baseline hypereosinophilia, and they might be at risk of future hypereosinophilia. And I tell them to be very vigilant for any new potential adverse effects, whether it's visual changes or abdominal pain. Most patients have no clinical consequence, but I will monitor them. I don't stop the therapy. I don't change the therapy. I'm looking at primarily their clinical efficacy, although I do tell them to be vigilant for side effects.
Right. We've got some great questions here. I want to thank you all for these. These are excellent. So here's a good one. How do you manage follow-up in patients with asthma, with both asthma and COPD? Asthma, COPD overlap, if we're going to call it that, if we're allowed to call it. Gina says yes, Gold says no. So, I see these patients in my practice. They have maybe had a history of asthma as a child. They kind of came back in their 20s. They smoked, and so now they have features of both. Or I'll see a patient with COPD who has allergies and has some evidence of T2 inflammation, and both groups are frequent exacerbators. So that's really the driver of whether or not we would consider them for biologics. The good news, based on data that was presented at this meeting, actually today, on the role of a biologic in COPD with the increased blood eosinophils, I think the future looks bright for this group. There may be some, and we can get biologics now, to be honest, if you write, especially if you focus on the asthma as you are writing the filling out the forms. But I think eventually there's a real groundswell to look at the biologics in patients with COPD who have evidence of T2 inflammation, and so then we won't have to maybe jump through as many hoops, and we can do this knowing that it's going to be beneficial. So there's several studies going on looking at biologics in these patients. So I'm excited about the future.
Okay, got some more great questions here. How do you assess the effectiveness of Montelukast, aside from asking the patient how they feel? That's a good question. I think you could ask it about all asthma therapies. Montelukast, as you know, is a leukotriene receptor antagonist. It was first approved in 1998, so once daily therapy approved down in both adults and childhood asthma. And, it's nice because it's an oral therapy. It's once a day. It does provide some anti-inflammatory effects and also some bronchodilatory effects. But, I have to think back about why did I start it at the beginning? Did I do it because of symptoms? Did I do it because of exacerbations? Did I do it because of low lung function? And I mark down what was the reason I started it, and then I follow back in 3-4 months, and I evaluate those same metrics. Did the patient have 2 exacerbations in the prior 6 months, and now they have none? Well, then it suggests it's working. Do their symptoms get better? Did their lung function get better? I do it for basically all the therapies that I add. I don't want to add a therapy that isn't working, and I have no problem discontinuing a therapy if there doesn't seem to be benefit or if there are some adverse effects.
So here's one good one for you. So here's one I think we should, there's 2 that I think we should compare and contrast how we would approach this. So there's just a good question about how long do you keep patients on biologics? If no response, how do you change it? If a good response, do you wean it? And how do you monitor? And then a second question related is what is considered the best practice for monitoring patients on biologics? Labs like renal function, hepatic function, serum asthma biomarkers, how frequently, spirometry testing, pheno, how often? All right, so I'll start and then I'll have you chime in. So we talked about today, you really try to give it your best using the biomarkers we have available. Now we have a sense of who responds in different settings using the algorithms we described. You give make your best medical decision on the biologic for your patient. But even in the best of circumstances with what we have in 2023, it's not a guarantee. So to give them a 4 to 6 months is usually what we do. You can go a little longer if you're not sure, depending on how frequent they exacerbated before the biologics. You can go as long as a year if you feel like that's necessary. But then if you're not really seeing a lot of change, usually by 6 months you have a pretty good sense. And it's important to keep track and be really systematic about it. So then at that point, you have a decision to make. Do you then switch to a different biologic, especially if they were potential candidates for more than one? So that would be the way to do it. And then I usually I will see the patients, especially early on in their tenure of biologics. I'll see them after their first dose, and then I'll probably go another 2 months, see them again, and I tend to see them every couple of months. And I'll do spirometry, I'll measure pheno, and then depending on the biologic, whether blood eosinophils are necessary. With the anti-IL-5 receptor, blood eosinophils go to 0. I want to make sure that's happening. With the anti-IL-4 receptor alpha, pheno goes down. So it's a good way of seeing if the target's been engaged. So what do you do around the space?
Yeah, so I think it's so important. I step back and, again, I do like a full reassessment. Did the biomarkers go down? What are the biomarkers now? Did we address all the comorbidities? Maybe we got rid of the eosinophils, but the patient still has ongoing reflux or sinus disease or some other process that is contributing to their asthma, vocal cord dysfunction, obstructive sleep apnea. So I go back to the drawing board as well in those kinds of patients, and I really want to know what could be going on. There's also some patients who will be partial responders. So maybe they had 4 exacerbations and now they had 2. But, did you lower eosinophils but their nitric oxide is higher? Those are the kinds of patients that can be challenging. Do we add or do we switch? And each patient requires an individualized approach.
Right. And along those lines along the lines of monitoring adherence, there was a question about using pheno to check adherence to ICS. And so I did have, I think back to patients of mine that I know, like purposely, they would withdraw their ICS on a biologic, and then their phenos would go up. And I had one patient in particular who kind of makes me smile because he knows he kept doing this, and I explained it to him. And so each time his pheno would be through the roof, and he would look at me sheepishly as I walked in the room. He goes, "I know, I did it again." And so you can use it, but I will say there actually was a rigorous assessment of this done by the NIH, the NAEPP guidelines in 2020, and they actually said in adult patients the data aren't strong enough to really recommend it for use to target to really monitor adherence. And so after sort of seeing that and looking at some of the data, I've decided not to really use it for that purpose, but to use it more as a potential diagnostic or as an ongoing monitoring biomarker, especially in the setting of biologics, to really monitor progress. I don't know what you think.
That being said, we're doing a study actually looking at this exact question about whether or not patients who are stable are able to taper their background therapy, their inhaled steroid, their long-acting beta agonist therapy. We know from the long-term clinical trials that when patients stop the biologic, many of them exacerbate, but at least and they need to go back on them in a vast majority of patients. if they're responders, but perhaps we can decrease the background therapy in some of these patients, and that's a study that we're doing. We're looking at predictors of who can stop these background therapies, the inhaled steroids, the long-acting beta agonists.
Exactly, because patients do this anyway, right?
Yeah,
they do
many patients, but this will give us confidence to say, no, you really need to stop it, or maybe you have a certain profile. Maybe your background eosinophil count was low enough that you don't need to be on the background inhalers.
That would be nice. Go ahead and ask your question.
All right, here's another one. We have so many questions here, and by the way, if we run out of time, because it's getting late this evening, if you want to come up afterwards, I think we have a minute or two before we scoot off to our other dinner, large plans with our colleagues that we have planned tonight. But do you see patients with EGPA manifest flare-ups of asthma despite being on biologic therapy? If so, how do you manage beyond oral corticosteroids? So EGPA, as you know, is eosinophilic granulomatosis with polyangiitis, Churg-Strauss syndrome. It's a syndrome characterized by asthma, eosinophilia, pulmonary infiltrates, neuropathy, sinusitis, vasculitis. It's usually eosinophilic, plus or minus anti-neutrophil cytoplasmic antibodies. We published a study a couple of years ago demonstrating that anti-IL-5 therapy with mepolizumab was effective in these patients, allowing corticosteroid withdrawal in over 50% of patients. We're currently doing a study looking at benralizumab, another one looking at a long-acting anti-IL-5 called depemokimab. So in patients with EGPA who have flare-ups, we're able to reduce by 50%. I usually treat those patients. If they continue to have exacerbations and asthma flare-ups, I step back again. What is the reason for their flare-ups? Do they have EGPA, but they also have high nitric oxide? Should I add another biologic therapy? Do they have other comorbidities that are contributing? Is it just respiratory tract infections? Should they be on a macrolide? I try to dissociate the asthma from the EGPA and treat them as separate entities. But they're very challenging patients. Many of them are corticosteroid dependent, and even though we can get them down to 4 milligrams or less, many of these patients, there are still patients who continue to flare. Some of them, it's because of adrenal insufficiency. Some of it's because of asthma. Some of it's because of vasculitis. So you really have to do an individualized approach.
Well, that's great, Mike. Here's another good question. What is the role of allergen immunotherapy in T2 allergic atopic asthma with patients on biologic therapy, but who still may be symptomatic or have exacerbations and have specific allergen IgE increasing in comparison to prior labs? So good question. So this sounds obviously like a very atopic patient, maybe an early onset asthmatic with a family history of asthma, maybe a concomitant atopic disease, along with allergic rhinitis, atopic dermatitis, eosinophilic esophagitis. So it's possible that they all can coexist together. So I work closely with my allergy colleagues since I'm not an allergist. Allergy, ENT, and pulmonary for this purpose. We're a great triad, and you might want to throw in GI as well, since a lot of these patients have GI issues. But what I'll do is if this sounds like a person who might be a great candidate for Xolair, for omalizumab, an anti-IgE, we'll see what the response is. Now, if the question would be whether after the omalizumab has started, there still may be a place for immunotherapy. And that's where I consult my allergy colleagues on this, because especially in the setting of specific aeroallergen sensitization that is maybe partially improved with omalizumab, but not completely. You know, it's again a shared decision-making phenomenon, because immunotherapy is not a small undertaking. It's weekly injections, trying to get up to a maintenance, and there can be exacerbations around this. So patients have to be very carefully monitored and have actually lung function FEV1 greater than 70%, really to be candidates for this. But I think we certainly have used that combination before.
Here's another one. In someone with severe asthma, eosinophils count greater than 300, low IgE, so an eosinophilic, non-allergic patient, not responsive or minimal response to dupilumab, who has mucus plugging and hyperreactivity with methicillin challenge PC20 of less than 8. Would you continue dupilumab and add tezepelumab to block TSLP, or would you discontinue the dupilumab and add tezepelumab? So would you switch, or would you add on? So this is the kind of patient where dupilumab has been shown to improve mucus plug. If the patient isn't fully responsive and they have airway hyperreactivity, I would probably switch them out to a different therapy from Dupi to tezepelumab to see whether or not, because it's been shown to improve airway hyperresponsiveness from the Cascade study. It's been shown to improve mucus plugging as well in a recent publication. So I would probably do the switch in that specific instance. Tezepelumab works a bit more broadly than dupilumab because it's upstream of IL-4, IL-5, and IL-13, whereas dupilumab just blocks IL-4 and 13. And on top of that, tezepelumab also plays a role in some of the non-type 2 settings in terms of ameliorating, abrogating airway hyperresponsiveness. So I'd probably do the switch in this kind of patient.
Great. So I'm going to give you this question, and I'm going to answer this one. Here's one. The role of TSLP in triggering both T2 and, oops, I can't read this little part, sorry about that, now is explained, but the probability of its failure in the long run remains a valid concern due to the redundancy of the immune system and the risk of IL-33 taking its role. Very good point. We saw all those as confusograms, as Mike calls them, that he showed you tonight. There's many pathways, and that's always been a concern that if you inhibit one, will others then take over? Now, TSLP being quite upstream and inhibiting lots of other pathways downstream, I think has the potential to continue to suppress. But again, I agree with you that I worry about other pathways becoming more active. And actually today, there was an interesting abstract presented using an inhaled TSLP and anti-TSLP and anti-IL-13 in an inhaled form in a phase 2 study that greatly reduced FeNO. There were some nice improvements, I think in lung function as well. Yeah. And so that's going to move on and really be studied, and that's very exciting. And so I think combinations of biologics, like we sort of talked about in the setting of T2 comorbid disease, I will bet you as the future, we continue to evolve, that we will have the ability to use combinations. Just for the reasons that you state, to avoid, really avoid tolerance, if you will, or and because of the redundancy of the immune system. So thanks for that.
We want to work broadly, and we saw how challenging asthma is. There's many pathways involved, so we probably want to be pretty broad and target multiple different strategies. So I think we have time for our last question here. Regarding remission, do you want lung function stabilization or improvement? Thanks for giving me all the tough questions here, Monica. I think it's a good question, and we're still defining what remission is. There's many definitions that have been out in the literature, and I think for some patients, really we want stabilization. Ideally, we'd like improvement, but we can't always get it because some patients have some features of airway remodeling that won't reverse over time. So ideally, it's stabilization. And if you can imagine a patient has no exacerbations, has no symptoms, and all you're dealing with is their airflow obstruction, which hasn't improved, I'd take that. So I think what we're really looking for is stabilization without any worsening of lung function. Right. So I want to thank everyone for coming this evening. I hope dinner was good. The pasta I had was excellent. And I want to thank Monica for sharing her expertise, and Nijra Lugogo and Jonathan Corren, who answered our calls from a friend and really gave some of their perspectives. I thought highlighting some of the disparities in asthma management were really important, and some of the novel therapies that Monica discussed. It's really, really exciting to be practicing severe asthma management these days. Yes. And I'm looking forward to the next few years as we develop newer therapies. And that's where the excitement, I think, lies, and what keeps us going in terms of our clinical and translational research programs.
Absolutely. I want to thank you all for spending your evening with us, and now it's time for you to go out and enjoy yourselves. And I've appreciated the questions were fabulous. You all are a very engaged group, and I think the future is bright for our patients with severe asthma. So thank you very much.